This is a presentation about brain stimulation techniques. These are the objectives. We're going to talk about the benefits of brain stimulation techniques and the various brain stimulation types of treatments. We're also going to talk about how to take care of patients prior to these types of procedures. So in a nutshell, brain stimulation therapies involve activating or inhibiting the brain directly with the use of electricity. Often the electricity is given or applied directly with the utilization of electrodes, either externally, non-invasively, or actually implanted in the brain. The electricity can also be induced with the use of magnetic fields that are applied to the head. These therapies are not utilized as often as medications and therapies, but they certainly have an important place in psychiatry. Electroconvulsive therapy is the best studied. It's been around for the longest time, and it doesn't have as good of a reputation because of history, maybe like One Flew Over the Cuckoo's Nest, but ECT is awesome, and the use of it now brings about a rather significant relief, especially when it's treating major depressive disorder with psychosis. We're also going to talk about these other stimulation therapies, RTMS, vagus nerve stimulation, magnetic seizure therapy, which is very new, and deep brain stimulation, which is rarely used. So first, electroconvulsive therapy. This uses an electric current that induces a grand mal seizure. Now, grand mal seizure is generalized, involving whole body. The electrodes are placed either bilaterally in the frontotemporal region or unilaterally on the same side as the dominant hand. So it's considered only when the patient's illness is refractory or treatment resistant. It is, however, the preferred treatment for MDD with psychosis and MDD with catatonia, those folks who have major depressive disorder that have been resistant to treatment and have a very high risk for suicide. And it's a very effective treatment. So the dose of electricity or stimulation is based on the client's seizure threshold. You want to have the seizure last for about 30 seconds. And that's going to give you the best results, and it's delivered over about 6 to 12 treatments on average. These are done over a 2-week period. Some people might get in upwards of 20 treatments. Usually folks will notice some benefit after about the 6th treatment. Some might require maintenance, and if they do require maintenance, ECT, after that initial series, then it may be just monthly. And that seems to really hold the effect. So it is considered first line for MDD with psychosis, especially when the patient is suicidal or homicidal. It can provide a fairly quick relief, and when I say quick relief, probably after 6 treatments, which would be, again, delivered over a period of 2 weeks. It's also indicated in the treatment of acute manic episodes of bipolar disorder, and really can induce a remission in some clients who are diagnosed with acute schizophrenia. I've seen it used rarely for schizophrenia, but probably in other, that's been just my experience. Contraindications, really the only absolute contraindication for ECT is if there is increased intracranial pressure from like a brain tumor. Maybe there's been a recent cerebrovascular accident or some other type of brain lesion. those folks who are also at high risk of having problems are those people who've had an MI or, again, a CVA within the preceding 3 to 6 months, the presence of an aortic or cerebral aneurysm, and underlying hypertension and congestive heart failure. So when you look at those contraindications, you're thinking about, oh, they're going to be at really a high risk if they undergo anesthesia. So anesthesia is really one of the biggest risks associated with ECT. So you have to make sure that these folks get a full workup, just like if they were going to have a surgical procedure. So the mechanism of action by ECT is, kind of unknown. The thought, though, is that, with the electrical current or that stimulation helps to increase the levels of the monoamines that includes serotonin, norepinephrine, and dopamine. The side effects. This is the big problem. Side effects are memory loss. Now, you don't see a whole lot of side effects there other than the memory loss. Oh, and some people do complain of the headache and some, confusion, feeling just kind of out of it after they have ECT. But the memory problem seems to be the biggest concern that folks have. Now, the memory loss can be kind of mild, or maybe just you forget a couple of days preceding the ECT, but for some folks it might be several months. It's just hard to predict. So mortality from ECT, really low, about 2 in 100,000 treatments. Death is rare and usually related to some cardiovascular complications. And again, that's more about any anesthesia reaction. So permanent memory loss, that would be really rare. Most individuals report no problems with their memory aside from that time period immediately surrounding the treatments. But some do report some retrograde amnesia that might extend back months. I had a patient once who had gone on a Hawaiian vacation before having ECT, and he lost all memory of the vacation, but he had some photos to help him, see what fun he had. At any rate, all clients, though, receiving ECT need to know about the possibility for some degree of permanent memory loss. So again, when you bring that up to patients, often that can be a deal breaker. Folks receive ECT in most often a post-anesthesia recovery unit. It needs to be in kind of a surgical type area where they're able to intubate and monitor just like they would in a surgery. So when a patient goes in to have ECT, they are treated like a surgical patient. They're NPO after midnight. They have an anesthesiologist present. They have an IV line. They have someone there to, of course, monitor airway. The psychiatrist is the one who delivers the electricity. Patients are reacted after the procedure. I know at Winchester, where I worked, we had a ECT nurse, and that was her whole job responsibility, was prepping people for ECT and then reacting them afterwards. Most of our patients are inpatient. Some people do opt to have ECT done on an outpatient basis. If they are eligible to do outpatient treatments, they do have to have someone who's going to be able to drive them to the hospital and pick them up, because you're not able to drive yourself home after having this procedure. So most antidepressants are, you can take without having to stop them prior to ECT, and that includes the tricyclics, the monoamine oxidase inhibitors. Antipsychotics can also be continued. Some stop lithium due to concerns that it might increase risk for a post-ictal delirium, and it can prolong seizures. So, I know we want a seizure, but ECT is all about having a controlled seizure. So you don't want a seizure that gets out of control. You want to stop clozaril and bupropion also because they can reduce your seizure threshold and make you more prone to produce late appearing seizures. Lidocaine can increase the seizure threshold, so that needs to be stopped, as well as theophylline. So you need to take away those medications that can decrease the possibility of having seizures and those that might induce it. So you want to have that control. Of course, anticonvulsant medications will also need to be discontinued, as well as benzodiazepines. They all need to be halted before ECT. So prior to getting ECT, patients need to have maybe a CT scanned, possibly an MRI, of course a complete medical history, an EKG to test cardiac function, and blood and urine chemistries. Patients are also given muscarinic anticholinergic meds, and these help to decrease those respiratory secretions. They do receive general anesthesia and as a result need to have airway management. Muscle relaxants are given to patients to prevent them from sustaining injury from having that grand mal seizure. So this is all of the types of machines utilized to monitor patients during the procedure. Some of the different electrode placements include that bifrontal temporal. This unfortunately can increase memory and cognitive issues and increase the risk of delirium because folks do get confused. Bifrontal, this has some issues because of the skull getting in the way, because that can reduce precision. Right unilateral is being found to be just as effective as bifrontal temporal, and it has less issues with memory problems. So follow-up, you need to consider the need for maintenance treatment, and it really helps if you do ongoing monitoring of the patient health questionnaire, which is the PHQ-9 screen for depression or mood symptoms. That can help you to know if you're actually having benefit or need to have maintenance. Medication management continues, and in fact, ECT can sometimes jumpstart the medications for mental health symptoms. So we're transitioning to transcranial magnetic stimulation, and this is a very relatively new type of brain stimulation. It utilizes a magnetic coil that delivers magnetic impulses to the prefrontal cortex. It is kind of expensive, but there's no downtime. It's a bit inconvenient because patients have to go to the office in an outpatient setting. They get the treatment. The treatment lasts about a half an hour, and it has minimal side effects. You can drive yourself home. Some people do complain of a little headache. They don't get any memory loss. The problem is they have to go into that outpatient setting 4 to 6 weeks, and that really cuts into people's time, and it's pricey, and insurance might not cover it. In fact, it's all really on a case-by-case basis. You have to be pre-approved by a psychiatrist and meet certain criteria before you can be approved. So if you're paying out of pocket, it's going to be $15,000 to $20,000. So last 30 to 60 minutes. I've never seen anyone go over 60 minutes with treatment. Hours on average at the clinic where I worked was 37 minutes. And the magnetic impulses, they pass well through the skull, and it's just, you see those electrical currents, and it really works in the same way that ECT does. But again, it takes a longer period of time, maybe 4 to 6 weeks, to notice the full benefit, whereas ECT is, you notice effects sooner. So vagus nerve stimulation, I've not seen this done very often. It delivers electrical impulses directly to the vagus nerve, and this impacts serotonin, norepinephrine, GABA, and glutamate. It's often used as an add-on treatment for epilepsy, and I've seen it used more often for that rather than the treatment of psychiatric illnesses. But it can be used for treatment-resistant depression. So with this procedure, a pulse generator is implanted in the upper left side of the chest, utilizing lead wires that are tunneled up to the patient's neck, and they wrap around that left vagus nerve at the carotid sheath. So 30-second electrical pulses are sent about every 5 minutes from the generator to the vagus nerve. So it operates continuously, and it's powered by a battery. Candidates must be 18 years of age or older, and the illness must have lasted for 2 years. So you get the point. It's for those people with severe, recurrent, treatment-resistant depression. It's often, this is not an attractive procedure because it takes several months for noticeable benefits, and it's still used in conjunction with traditional treatments. Side effects, this is interesting. Voice changes or hoarseness, cough or sore throat, neck discomfort or tingling in the area where the device is implanted, breathing problems, especially during exercise, and difficulty swallowing. And of course, this is all because of the vagus nerve. So this is a treatment I've not, it's very new. I've not heard much about it, but it's magnetic seizure therapy. It seems like it's going to be the wave of the future. It's a lot like ECT and aims to induce a seizure just like ECT, but the pulses are given at a higher frequency than what we use in TMS, but it's magnetic impulses. Patients do need to be anesthetized, and they still need to have a muscle relaxant to prevent any types of injuries from occurring when they have that grand mal seizure. It is better than ECT in that it reduces the cognitive deficits or memory problems that you see with ECT. It can trigger remission from major depression or bipolar disorder in 30 to 40% of individuals, so that's a pretty good percentage of success. Side effects is like ECT, that exposure to anesthesia, but the studies show fewer memory side effects. They don't need to have as long of a seizure, and they have a shorter recovery time. And if you want to know more about it, you can click on this link for the NIMH. Deep brain stimulation, I've only seen that used once in my private practice, and it was initially developed as a treatment for Parkinson's disease. Now, I did have a patient who had Parkinson's who had this brain stimulation, this electrode implanted in his brain, and it was controlled by a generator, and every once in a while he'd have to go down to like UVA and have it adjusted, but he had some ability to adjust it himself, so that was interesting, and it would help with tremors, those types of issues that people have with Parkinson's, but again, it's also used to help treat people who have depression. Here's some more information about deep brain stimulation. It is pretty invasive and, again, not used very often. So, it carries the risk that you see with brain surgery, bleeding in the brain, infection, people get disoriented, maybe confused, might have some unexpected, unwanted mood changes, movement issues, lightheadedness, and some trouble sleeping. So again, pretty invasive and not used very often. So here's our summary. Yes, brain stimulation procedures hold a lot of promise for the treatment of mental health disorders, and most of these techniques still are used in conjunction with other traditional psychiatric treatments. Thank you.